Good afternoon, everybody, and welcome to our final Ask the Experts of June. My name is Sue Weldon. I am the CEO and founder of Unite for Her, and we are always honored to bring all of these education series to you front and center. Today, we are streaming live on Facebook, so we wanted to remind you that we love that this can be interactive. So those that are watching, please put your questions, join the conversation in the chat. I actually have my colleague here, Rachel, joining us, so she's going to make sure she's watching any questions that are coming in. We've already gotten quite a few, so we are prepared to answer those with our guest speaker today. And we are so grateful that you've joined us, and this is a way that we can actually bring the most up-to-date information on topics that are front of mind to our community and really tie you with the experts in the field. When we start today's speak or Ask the Expert, the topic is rethinking palliative care. And this topic has been talked about quite a bit at Unite for Her and also with our partners at the NBC Alliance. We did a 4-part series about a year ago on this topic, everything from really understanding what palliative care is and what it is not, thinking about how we should possibly even change that name because the connotation is so put into one lane for our community, thinking that palliative care is only for people who may be living with metastatic disease. And that's just not the case. So today we're going to get so much understanding on this topic, really give you a lot of information, how to lean in, how to access, and really give you an understanding of what palliative supportive care is. Now, before we get started, I just want to thank our sponsors, and we cannot do what we do without them. They are extraordinary. They truly help our Unite for Her Connect bring in the best of the best all year long, right? Over 61 series that we do a year. So please give a round to our presenting sponsors, recognizing them for all the goodness that they have brought to Unite for Her. We have West and Merck, Lilly, Gilead, and Novartis as our presenting sponsors. And then we have Pfizer, GSK, Daiichi Sankyo as our gold sponsors, and Agendia, TerraSera, and AbbVie as our supporting sponsors. Again, we are most grateful. All right, so I think it's time for us to lean in. And it's with great pleasure that I get to introduce our speaker today, and she's not a stranger to Unite for Her. We've been fortunate to have Dr. Cubbison on our speaker series in the past with the NBC Alliance. And we are so grateful that she was able to join us today. So before we get started, I'm going to do a little bio on you. So Dr. Caroline Cubbison is a board-certified palliative care specialist. She's currently serving at the Dana-Farber Cancer Institute and Harvard Medical School in Boston, Massachusetts. She is committed to enhancing the quality of life for patients with cancer and other serious conditions through expert symptom management, assistance with communication, and coping support. Dr. Cubbison champions a patient-centered ethos, consistently striving to align medical interventions with individual values and goals. And beyond her clinical practice, she's engaged in national and global initiatives to raise awareness and broaden access to palliative care services. So please join me in welcoming our special guest today, Dr. Caroline Cubbison. Dr. Cubbison, thank you for joining us, and it's so good to see you again.
Thank you so much, Sue. I'm thrilled to be back. This
Yeah.
is a topic that's very, very near to my heart. And so I'm just grateful to be able to share some, thoughts with the breast cancer community.
Yeah, agree. And we even had a little bit of a chat prior to jumping on live, and it makes me excited to see how this space is expanding, reinventing itself, and making it so much more accessible to everybody. Very similar to Unite for Her's comprehensive care approach that we give to our patients. All the information that you shared with me, early on, just made me have so much joy because we know there's been this push-pull, about palliative care. So how about if we get started? We'll dive right in and we'll just start with the basics. Like, what is palliative care?
Absolutely. This is the question that I ask every patient when I meet them the first time is, what have you heard about palliative care? Because I think people have heard either nothing at all or really scary things that intimidate them. And so I always like to just start with describing what palliative care is through my perspective as a palliative care doctor. And I explain it in the following way. Palliative care is a field of medicine, just like oncology, where we provide a couple of different things. One thing that we do in palliative care is really expert symptom management. So, people who are trained in palliative care have done additional training that many oncology teams may not have done themselves around symptom management. Symptoms like pain, nausea, anxiety, difficulty sleeping, low appetite, um, constipation, diarrhea, sort of anything physically that someone might feel, whether it's related to their cancer directly or side effects from the cancer treatments that they're getting. We have additional training that really lets us think outside the box and think creatively to offer really advanced symptom management to help someone feel as well as possible as they're living through cancer treatments and living with cancer. Um, we also help with another thing that you mentioned earlier, which is the communication piece, right? So we get additional training in how to optimize communication between patients, their families and loved ones, and their medical teams. Not infrequently, I hear that, doctors, as good as we try and as best we try to communicate effectively with our patients, sometimes patients feel like they're drinking from a fire hose. They're getting so much information tossed their way at all of these clinical visits, and it's hard to sort of keep track. Wait, what does this mean? What does that mean? What did the doctor say? What is this treatment? What are the side effects that I can expect? And it can become hazy and confusing, especially with something as fast-paced as the ever-changing landscape of cancer treatments. And additionally, we hear from patients that sometimes it's hard or even scary to have conversations about their health with the people they love most, maybe because they don't want to burden people or they don't want to worry people. And so this is something that we explore with patients and families and their loved ones and caregivers. And we just sort of see, are there parts of the communication either, with the people who are helping take care of you or that you're close with, or with your medical teams that you're not sort of totally sure about, or that you want some extra help with, or you have questions on your mind. We want to help navigate and bridge that for patients. And then the other thing that we do is we try to add an extra layer of support, right? So I talked about the symptoms that we can help with, but we know that physical symptoms are only one part of what it actually feels like to live with cancer. We know that there's a lot of emotional distress, a lot of spiritual distress, a lot of social distress that comes with a cancer diagnosis. And we also want to be attuned to that and checking in on that and providing additional support there too. So that might look like just leaning into some topics, some worries, asking patients, what are you hoping for? What are you worried about? We know that sometimes these conversations can be hard to start, but we have heard from patients and from research that patients want to be able to talk about these things openly to sort of get them off their chest. And so we want to be there and be able to provide a space for that as well. And also think about, are there other things that we can tap into, other specialists, whether it's social work, psychology, integrative medicine to help again add that extra layer of support no matter where the need is coming from. And so, when you think about all that we can do in palliative care, a lot of it, I think, just sounds like common sense, right? Like it doesn't matter sort of what your
Sounds like our
diagnosis
program.
is, right? It's like you would want any patient to have that, even if I had an infected toenail, like that just sounds like a good thing to have. And
Yeah.
so we are really seeing that the benefits of palliative care and sort of this almost it's more like supportive care in a way, right? Really can benefit patients at any stage and any diagnosis, especially when living with something like cancer. And so I think one of the big misconceptions and one of the biggest worries that patients tell me when they come to palliative care is like, I heard that palliative care was only for people at the very end of their life, and I just don't feel like I'm there right now. And so people are really scared when they hear their doctor say that, I think you would benefit from palliative care. And we're really trying to change that because we know that, again, all of these things can benefit anyone. And the earlier you have access to them, the better your quality of life is going to be, no matter if, we're aiming to cure you completely of this cancer or your doctor thinks thinks that you have a great prognosis, or if this is something that you're going to continue, living with for years or even decades, right? And so we just want to be there to meet patients where they are and really try to offer them that kind of support. And so I'll say that the last thing that I know we were talking about before we got on this call is actually whether it's worth sort of describing what we call even like palliative care with that name that feels so heavily charged. And I'll say I think many centers, and the center where I work at specifically, we're actually thinking about renaming what we do because of the heavy charge and sort of stigma that even comes with that name. And our department, actually, we're now called the Department of Supportive Oncology because that feels like it more accurately reflects what we try to do for patients and families. Um,
I love it. No, I don't want to interrupt you. Just keep on going because everything that you said, it's what Unite for Her does. It's that comprehensive support. Like everybody should get access to what we give, right? And unfortunately, we're just for breast and ovarian cancer patients. But what we give from the nutrition support and the GI issues and the counseling and the emotional issues and movement and just getting your, well-being and your exhaustion and your energy levels up through movement and supportive type of fitness. It's all of these different approaches are there for the taking, right? And for you to offer. So to have a center that has this, it brings me so much joy that you are changing your name. I know that we had talked about, well, maybe we just need to continue to educate, right? And get people to learn that this word means all of these other things. But it just wasn't happening quick enough. And it's almost like once you have that in your mind, it's hard to erase it, right? It's hard to unsee it and unsee that meaning that you thought it was. So thank you for that. You answered actually my second question just about, well, how is it different from hospice care? And you could lean into that more, but I know you did mention like this is not hospice care. This is not
that's right.
hospice care. So why don't you share a little bit more about that?
That's right. So, I mean, the biggest distinction is sort of just acknowledging that this can benefit anyone sort of at any stage of illness, whether you were just diagnosed or whether you've been living with this for many years, um, and sort of regardless of your prognosis, too. I think hospice care, just to talk a little bit more concretely about hospice care is also really great medical care for the right patient. And usually, when we're talking about hospice care, we are talking about someone who is unfortunately closer to the end of their life. So that, maybe in the last 6 months of their life, but not just as in the last 6 months of their life, but has also really decided to focus just intensely on symptom management and to sort of forego active cancer therapy. And that's the big difference is that sometimes patients come and they worry that if they start with palliative care, that means that they're going to have to give up their cancer treatments. And that's not true at all. You can get palliative care and all of the support that it offers, including expert symptom management, while you are still receiving active cancer treatment. And that's what I want people to take away is that you can have palliative care while you're still getting cancer treatment. You do not need to stop cancer treatment if that is important to you and you want to continue.
Right. Perfect. Tell me a little bit about who all provides palliative care, because I heard you talk about your center, incredible, extraordinary. We know that not every center around the US, we have a national audience, offers this. So could you give us an idea of who provides palliative care and how our audience watching today might be able to get access to some kind of services?
Absolutely. Um, the first thing is recognizing, of all the things that I said, the symptom management, the communication, and the like understanding what matters most to people and helping navigate that piece, and also assessing for other areas of concern or worry. Um, one person probably can't do it all, right? And I think that that's something that we probably don't recognize enough in medicine, which is we really recognize and value the expertise and the training and the dedication and knowledge that many different people from different training backgrounds can bring to a patient to provide support in different areas. Okay. So palliative care leans in I don't want to say more than other medical specialties, but it's definitely one where I've seen it work the best. And my hope is that the future of medicine in general for all specialties starts moving in this direction because I've seen how good it is for patient care. It really leans into what we call this interdisciplinary or multidisciplinary team-based model. That means that, yes, you have your typical doctors, so someone like me, but we also partner and work closely with nurses, nurse practitioners, social workers, psychologists, psychiatrists, even spiritual leaders or chaplains, sometimes even specialty pharmacists. And so each person on that team brings their own expertise to a patient's care and is able to offer, I think, a very robust support. Now, you're right. We are sort of in an abundance of riches here, and I'm so grateful for the patients who receive care someplace like Dana-Farber. And I know that there are many other incredible cancer institutes across the United States that also share this, vision for what truly amazing palliative care and supportive oncology is. Um, I think you can still count on some multidisciplinary team, even in smaller teams in more sort of rural or less academic medical centers, because I think palliative care really values that. And in fact, our national organization, the American Academy for Hospice and Palliative Medicine, is founded on that. So we are integrating social work, chaplaincy, nursing, and physicians constantly. And so I do think that at a minimum, people can expect their palliative care team to be composed of not just doctors, but a couple other people with different backgrounds and training. Access is a tough question, right? Because I think there's a growing awareness that this is really important to be able to offer patients. And it feels like we can't catch up with the demand, right? We need to train people in this. That takes time. The workforce is growing. We're still a relatively young field in medicine. I mean, palliative care really didn't sort of start formally as a field until the 1970s, which in the history of medicine, we're sort of just out of our diapers, so to speak, even though it's been 50 plus years since that time. But the point is, we're growing, but probably not fast enough. And so sometimes people may not know how to access this, or resources might be more limited depending on where you are living. I would say if you are a cancer patient, the first place that you should check in about accessing palliative care would be your oncologist, your oncology team, because they probably know better than, someone else, a different doctor, like a cardiologist or a kidney specialist. They would know who is providing palliative care in the community that you live in and have probably partnered with local palliative care teams on different patients. And so that communication directly between the palliative care team and the oncologist, I think, is important. Now, having said that, we also want to empower patients and families and loved ones and caregivers to sort of search for palliative care teams on their own if they're interested in doing their own sort of research. And so there is a organization called the Center to Advance Palliative Care that has sort of a national database of palliative care providers. And I believe we're going to share a link with the audience where you can punch in your zip code and specify if you're looking for palliative care resources either in a hospital setting or someone that could come do home visits at home for you, or someone with like an outpatient office that you could go to, like when you see your oncologist outside of the hospital, could you go see a palliative care doctor outside the hospital or palliative care team outside the hospital? So we want to share that resource with you all too, so that you can sort of look up by your zip code who might be nearby, just in case your doctor doesn't have a lead. But I would wager that I would hope most oncologists would have some sense of who's in the community. This is a good time to also share a disclaimer that everything that we've just talked about how the benefits of palliative care are not limited to those who are just at end of life. That is something that we recognize in our palliative care community strongly and is a growing awareness in oncology. But not all oncologists might actually know this. And so it actually might fall a little bit on you as the patient or the loved one or the caregiver to sort of advocate and say, you know what, I heard that this is good. And if it's not going to hurt me, why not try it? And so really sort of don't shy away. If your doctor tells you like, oh no, palliative care is just for end of life, I would push them on that because that's something that's changing in our culture, especially in oncology care. And I think if you're interested in it, you should definitely go ahead and push for it. What's the worst that could happen, right? The worst that could happen is you meet someone who's like, obviously I'm biased, but I always say it's kind of hard to find a mean person in palliative care. So the worst that could happen is you meet with palliative care and they say, you know what, we think you're doing great, and we actually don't think that we need to necessarily follow up that much, but we're here if you need us in the future. And so I don't think that that's a bad thing to explore worst case scenario.
Yeah, I agree. And you heard it first, for our community. It's good to see the advances happening in all of these different types of services. And this is one of them that you said, we're basically a new in the field. 50 years is new, and you're seeing the change. And I see that change just by having conversations with you. So we appreciate anything we can do to have our patients become advocates and have agency. It's very important. You talked about how you changed the name over at Dana-Farber. Do you think any of your societies that have the institutes are going to be changing their names as well? You talked about the Center to Advance Palliative Care or the Society for Palliative Care. Would they be shifting that name too? Do you see that following suit?
That is a really good question, and I think you would find strong debate on both sides.
Yeah,
So it's sort of above my pay grade on that one.
gotcha.
But it's
Gotcha.
definitely a conversation that we're having as a national society because I think that we recognize the challenges that we're up against, especially when we're sort of trying to spread the word and improve access to this.
Yeah, and then you could just because you have done it at Dana-Farber, just measuring before and after changing the name, how many patients came through the door, how many patients are serving now. You wonder if there's this metric that you can share that will help them see the changes necessary. And again,
Absolutely.
yeah,
Yeah. And I know that MD Anderson in Texas, which is one of the largest palliative care research centers, they've done a ton of work too, and sort of actually demonstrating over time they're seeing patients earlier and earlier and earlier, and patients who are not metastatic, but initially diagnosed stage one, stage two, sort of for all intents and purposes going to do well, and we're still seeing the benefits in those populations. And so I think that this is something that we're going to be talking more and more about in the years to come is when do we come into play, and how do we sort of introduce our services in a way that's really patient centered and helps people feel supported and doesn't scare them necessarily.
yeah, and having these conversations, even with us knowing how big our community is, we do integrative care. We do wraparound services, right, to help support them so they have the best quality of life, the best chance at managing their side effects and symptoms, the best outcomes. Who would not want that? I feel like you're saying the same thing. Who would not want to have another team right there by your side, right? All these tools in your toolkit, and you can decide if you want them or not. There's no harm, no foul, right?
That's right.
You can make a decision based on the knowledge that you have, but at least you explored it, you tried it out. One of the questions was, when should we start palliative care? So I think you touched on that a little bit, saying that you're seeing the shift change.
Absolutely, absolutely. And I will say, we think about palliative care as there's primary palliative care and then there's specialty level palliative care. And it's sort of like when you go to your primary care doctor and maybe they start you on a blood pressure medication. That doesn't necessarily mean that you need to go to the cardiologist, right? So it's sort of like, when do you say, okay, no, you really need a cardiologist, or like you really need a palliative care expert? And I do want to give credit. I think oncology teams do a great job and are constantly learning and evolving and sort of beefing up and increasing their sort of primary palliative care skills. So the question of when does someone really need to level up to that specialty level palliative care is something that's a little bit more of a gray zone. But I would say, when symptoms are present and sort of impacting someone's daily activities, when there are sort of larger conversations about worries or concerns that patients have, or communication gaps that patients have that they feel just aren't being met, those are sort of the two situations that I think we could level up to that specialty level palliative care. Um, yeah,
Yeah, it's great. Thank you. I'd love for you to put those two questions in the chat for me, and then we'll have Rachel put them out there too.
Okay.
It's always good for our patients to know what to ask and what to think about, right? As they're
Yeah.
away. One thing that we think about often is the management of the side effects and symptoms. And you talked about it a little bit in the beginning. Do you want to just run through that one more time so our community knows some of these side effects that you are looking to accomplish with that whole team, that whole comprehensive approach?
Absolutely. I think the biggest one, honestly, that I see coming through my door is pain. And pain, especially for the breast cancer community, and cancers that receive hormonal therapies a lot can be complicated because I have many patients who come in and tell me it's like they're like thrust into menopause all of a sudden as a side effect from their treatments, and suddenly, they've got achy bones and joints everywhere where they didn't used to have that. Or maybe they're having, pain at the site of a prior surgery or radiation treatment, or if there's a little tumor somewhere that's causing a lot of pain. And so pain management is one thing that we do a lot in my clinic. And pain management needs to be tailored to each individual. The best medicine for me to control my pain may not be the best medicine for you, Sue.
Yeah.
Every patient is unique, and every patient, when we're doing a pain assessment, we also need to know what's most important to patients. I'll just name, I think when I've been working with breast cancer patients, many of these patients are young. They are leading active lives. They are caregivers for older adults and younger children or teens. And so that is something that they really want their pain management regimen to also take into consideration so that they're able to show up and be present in daily activity as much as possible. And we really need to tailor each individual's pain management regimen to what they're hoping to be able to achieve in terms of functioning day to day. I have found that a lot of people are really worried when they come to palliative care that we're just going to give them morphine or opioids. And the truth is, we have many tools in our toolbox that allow us to think creatively to try to get people better pain management that closely aligns with what they want and what they're hoping for. We lean on not just medicines by mouth, systemic medications, but we also think about outside of the box. Again, there are other things that we know can help with pain management, whether it's focusing on different injections or different procedures, like radiation sometimes can help with pain too, and different types of specialists, like a chronic pain or an interventional pain specialist assessing someone. We're trained to think about all those things. And that way we can sort of offer the largest sort of suite of services to the patient. Say, look, these are our options. These are the medicines that we might think about, but these are the other things that we also might think about. And sort of saying, based on what I've heard from you, what's most important to you is A, B, and C. Therefore, my recommendation is let's try this, but let's also think about that and maybe meet with someone to explore what this might look like for you. And so I think that's really important to just share with the community, is that opioids are not the only thing that we have to offer. In fact, I'll just name two things that I find very helpful for the breast cancer community, particularly around the hormonal fluctuations that are related to treatment and sort of that, hot flashes and bone and muscle aches and pains are the two big ones that I see in my clinic all the time related to breast cancer treatments. And so I would just say one medication that I have found very helpful is a medication that is, well, there's two medications that fall into this category, gabapentin or pregabalin, also known as Lyrica or Neurontin. Those medications have found very helpful to be with sort of the musculoskeletal, like achy bones and joints. And then the other medication is one called duloxetine or Cymbalta. This is a medicine that also helps with that, but also both of these that I'm mentioning, the duloxetine and the gabapentin and Lyrica, they also help with hot flashes. So I found that it's very helpful to think about those things. And a lot of my breast cancer patients, when they come to me, they've never tried them before. And we try them and they can be a game changer for people. So I just want to put that out there in case anyone's listening in and is feeling like, oh gosh, I've never heard of those before. Maybe talk to your doctor about them, I think they can be helpful in the right person.
Yeah.
Um, but pain isn't the only thing that we see, right? As I mentioned, we see lots of nausea management also a lot of times treatment related. We see anxiety and difficulty sleeping because I think it's natural to have worries when you're living with cancer and, talking about that and also thinking about what medications can help with that. Um, we see a lot of GI side effects other than nausea, bowels either being constipated or diarrhea, sort of the whole spectrum. And we have different things to offer for each. Again, with the goal of letting people resume or get back to their daily living, because it's hard. And I feel like a lot of times when people are not feeling well, they tend to stay home and they tend to isolate and not participate in their life the way that they want to. And we know that there's a better alternative and we should try. Um,
It's good. No, I love hearing all of this because when I think of the community that's listening in, Unite for Her offers so much for all of the symptoms that you have talked about as well. And now they even have like a broader menu to choose from, right? Like they can utilize their passport. Maybe they're doing the acupuncture for the hot flashes, but they're also looking into something that you talked about for the bone pain. And there's a lot of different ways to manage side effects and symptoms, but to know that like collectively, collaboratively, if we have Unite for Her's integrative care program, 300 providers, right? Dr. Cooperson, like just like you said, it's a big team in order to have that specialty and have something work for you individually, not always one size fits all, but then to have this expansion of all of these other services. I just think that you're offering now a whole nother avenue for people to explore, and it just makes them, stronger and get their life back. We hear that often, right? The doctors are trying to save their life, and Unite for Her is giving them their life back, right? Palliative care giving them their life back. Um, a question for you is, I know we've done a couple different series on managing with medical marijuana and cannabis. Do you have that as one of your, I know they have topical creams and sometimes pain management aspects to having a clinical care plan for cannabis. Do you
yeah.
know much about that?
Yes, yes. And so I would say I think that's another area that's sort of a little bit taboo for some people, and they're worried about talking about it openly with their providers. And I wish that we could also minimize that stigma around it because I do see a lot of patients, trying cannabinoids, cannabis products. And frankly, a lot of people feel like they're very helpful, and I think that there's truth behind that. I think what's challenging about cannabis is that because of the way that it's been regulated and sort of the schedule of drug that it's been categorized as for as long as it has been, it's really limited the amount of research that we can do into it. And so I think sometimes doctors are worried about saying definitely hands down, this is going to work 100% and, take it at this dose. So that's why I think more people don't talk about it openly. However, in palliative care, I think we have additional training many times in thinking about cannabinoid therapy and there is a body of evidence that's growing that it does help with particular symptoms, like nausea is a big one. Nausea that hasn't responded to like our typical nausea medications. That's a group of people that we have seen really benefit from cannabinoid therapy. We know that it also helps with pain and anxiety through different pathways. Um, and so that is something that we talk about with our patients. And we can often find a way to medically certify the patients too, so that they're getting that additional support. Because unfortunately, many cannabis products are not covered by insurance, but we do want to help sort of offset some of the financial constraints around this tool, which I think is helpful for many people. And there are studies that show that one out of every sort of 3 to 4 cancer patients may be using cannabis products. So you're not alone, right? You're sort of in good company if you're in that boat. But people feel worried about talking about this openly with their doctors because they're worried that they're going to be looked at, or as someone who is misusing cannabis, or someone who is, off the deep end and doing something that's sort of not safe or not medically sound. And I just wish that we could change that because I think more than often doctors want to help and want to know and help guide and coach patients. And that's, I think, something that we're more comfortable with in palliative care because of the nature of our work. But I also hope that that's something that's shifting in oncology in general.
Yeah, well, we're trying to do that as well and just normalize it, right? And demystify it and allow patients just from this conversation. The fact that you said, "Oh yeah, we talk about that." That's so positive, right? Now our patients can be like, "Okay, I'm going to talk about this. This is not something that I feel like there should be a stigma about." And if you're
Yeah.
saying that 1 in 3 or 1 in 4 are using anyway, don't you want them to be the most educated as possible on this type of treatment? I think of the way we choose our oncologists and our surgeons and radiologists and all of those different professionals, like we get second opinions. But it feels like for medical marijuana and cannabis, we just sort of dive in and don't get the education that's
Hmm.
necessary. So that's been something we've been really working towards. And I think more and more people being open and honest and making these conversations normalized, you'll find more education about it. So we've done quite a few, probably about 4 now on that topic, and we're hoping that it just helps our community understand how to use it in a way that's gonna really be effective for them. And like you said, they wanna live their life. They wanna drive. They wanna be with their children. They have a presentation to make it work. They're executives. They're people who
That's right.
are
Yeah.
needing to not, have any type of side effect from the pain management therapy of choice, right? So you talked a little bit about not being covered by insurance. Can you tell me if palliative care is covered by insurance?
Yeah. So I would say, obviously, disclaimer, like every insurance plan is unique. And so I think every individual, should verify. In my experience, Medicare, Medicaid, and most large insurance companies, once they're paying for oncology care, once you've got a cancer diagnosis, sort of palliative care is not the thing that they're going to draw the line at. And so I've been, I've encountered that I have not had patients tell me like, "Oh gosh, I can't access this because, my insurance won't cover it." I think by and large, if you have a cancer diagnosis, palliative care will be covered by your insurance. Of course, always leaving some wiggle room for plan specific, constraints. They may want you to see one palliative care team versus another if it's like out of network or something like that.
Yeah.
But I think by and large, yes, palliative care is covered for cancer patients.
Perfect. And do you have time for one more question?
Absolutely.
All right. How does palliative care support the caregivers and the families?
Thank you for bringing that up because I think not enough attention is given to caregivers and families.
Mhm.
And cancer is one of those things that doesn't just affect the patient, but it affects their whole support system.
Yeah.
And that's one of the things that I really appreciate about our field is that again, I think part of it is this team-based approach where we have so many different people, trying to address with their lens, with their expertise. We sort of recognize the distress that is happening in the larger family, not just in the patient. And we try to facilitate communication between all party members. Um, I'll say sometimes also patients may not want to talk about something, but their family member does. And so sometimes we help navigate that and say, would it be okay if we talked to your loved one sort of without you and just sort of hear what they're worried about? Many times patients are like, yeah, totally, like support
Yeah.
them, but I don't want to talk about this. So it's something that we try to negotiate. But I think we need to pay more attention to just in general cancer treatment, the impact of this, not just on the patient themselves, which of course is enormous, but also on everyone around them that's helping support them and leaning into them and checking in with them. How are you doing? How is this affecting you? What can we do to support the family at large or the support system at large? Because we know that that's also going to help support the patient, right? You got to
Yeah.
support the caregiver.
Yeah, I think there was a study that I heard that a lot of physicians can sort of see when someone comes into their office and they're alone and they don't have like those loved ones around them, they're not doing as well as
Yeah.
when someone comes in and they are just have that key person or that team that's there to lift them up. And this is that team, right? Unite for Her becomes that team, right? Sometimes we don't have that team personally, but this is the one that you can lean into, whether it's a palliative care team, Unite for Her community, looking for ways that we can be there right with you step by step. So is it covered as well for the caregivers? Just being able to get some access to your team, to get some knowledge about support?
I I would say many times I'm sort of reaching out to the caregiving network as part of the patient's care. So I see it sort of all being
Yeah,
related to that individual patient's care
yeah,
plan. I don't see it as being separate. So it's not like I'm seeing, someone separately and sort of billing that other
yeah.
person's insurance separately for a palliative care visit, right? It's all related to the same patient's care. But through working in that model, sometimes we can identify, okay, gosh, this person is really struggling with X, Y, or Z. Maybe I should connect them to social work or a resource specialist to talk about. Can we connect them to other resources in their community? And so that's sort of all. I think because we know how much it impacts the individual patient's care. I see it as being part of that patient's care plan, not separate. But again, we're just attuned and checking in on that so that we can then offer resources for that other person
Yeah. Make them
privately and
feel
sort of
heard.
separately.
Yeah. For them to be heard and seen and
Yeah,
understand how much it affects them and
yeah,
sometimes creates a space of illness and depression as well. Just acknowledging that can really move, right? Move the needle for them.
yeah.
Yeah.
That's right. That's right.
Yeah. Oh, Dr. Cubbison, thank you so much. I always enjoy talking to you, and we appreciate all of your knowledge and everything that you bring to Unite for Her at this topic for SE experts. It's a big topic, and I'm glad to hear that it's starting at different stages and not, having that stigma of only that stage 4 last stage approach. So we did put some links in the chat, some of the speaker series, and we had the changing the conversation in palliative care with the MBC Alliance that Dr. Cubbison was in as well. And then, of course, the link that you had talked about to go to the Center to Advance Palliative Care to put in your zip code. So we have all of those links in our chat. We appreciate you. Thank you for being here, and have a great day.
Thank you so much for having me. And it's such a joy. And I hope that, many of the patients and families listening in today will ask for palliative care support because I think it can be a wonderful thing. And please do not shy away from it.
Yeah, thank you. Perfect. All right. Until the next time, I'm sure we'll be speaking again. Yeah.
Yeah.
All
Bye
right.
bye.
Thank you. All right, Unite for Our Community, that does it. That wraps up our Ask the Experts for June. Thank you all for coming out. Always such a good topic when we have people like Dr. Cubbison to join us and give us all her knowledge. It was truly, truly a very thoughtful, knowledgeable session that I know I learned a great deal. We have 3 more reminders for our community. Number 1, we would love for you to connect with our registered dietitians live. It's the last Friday of the month, and it's live on Instagram. It's called Dear Dietitians. It's such a good segment. You can ask our dietitians anything that's top of mind, and they will answer for you. So it's at 10 o'clock this Friday, the 27th, and then every Friday, last Friday of the month. And then don't miss out on Monday, June the 30th. And every Monday up until July 21st. We're actually going to do a live acupressure type of treatment for cancer support and wellness workshop. We're going to be joined by Jacqueline Laklava, and she is a Master of Science in Acupuncture and Oriental Medicine. She uses acupressure treatments to offer individualized care to support comfort, resilience, overall well-being. So please join Jacqueline every week to learn more about how acupressure can be used to support your cancer journey and with your overall health and wellness. And then third is understanding the pelvic floor. So that's going to be on July the 17th at 6 p.m. Eastern Time. We'll be joined by Samantha Shodel. She is a pelvic floor lead therapist, sorry about that, at Penn Medicine, Doylestown Hospital, for an informative session on the pelvic floor. This is what it is, how it functions, and how it can be impacted by cancer. She'll also highlight how working with the pelvic floor specialist can help manage side effects and symptoms associated with various conditions. So to register for all of these above that we had talked about, please go to unitefor.org/UFH Connect. Again, thank you to our sponsors. We can't do what we do without our presenting sponsors, which you see right behind me. That is West, Merck, Lilly, Gilead, and Novartis. We are so grateful for all their support. In addition, we have our gold sponsors, Pfizer, GSK, and Daiichi Sankyo, along with our supporting sponsors, AbbVie, Agendia, and TerraSera Therapeutics. All right, everybody. Thank you for joining. Have a wonderful weekend and a great afternoon. Bye.